Good evening, ladies and gentlemen. Welcome to HRS 2023. My name is Dr. DJ Lakkireddy. I'm the Medical Director for Kansas City Heart Rhythm Institute in Kansas City. We have today Dr. Christopher Ellis from Vanderbilt University, Nashville. So we're going to do a little session on what's up with left atrial appendage. So, Chris, how you doing?
Good. Good to see you, DJ. Thanks for
Excellent.
bringing me on HRS TV.
Fantastic. So I know, you're a well-recognized international expert in the left atrial appendage closures. And some of the things that have recently popped up to the surface, I think we've gotten so good at it, and we have improved the safety profile of it, and the efficiency of implantation has gone up much better. So, but one common theme that keeps coming back is this theory of peri-device leaks, right? So what do you think of this, and what are some of the scenarios that you typically come across these leaks?
Yeah, so for sure we've ramped up the volume, done hundreds of thousands of these devices, and still see a consistent maybe 10 to 20% leak rate if you look for any leak. And it had been, I think, an odd thing that we would generally say, oh, less than 5 millimeter leak, don't worry about it, when the first series of these trials got done. But as we've done so many patients, we start to see event rates tick up in patients that have leaks. So the old concept that a 5 millimeter leak or less was like a carte blanche to stop anticoagulation, I think we're taking that back and re-looking at it. And where that measurement is, 1 millimeter, 3 millimeters, 5 millimeters, not entirely clear, but some of the data that's been coming out, some of our longer term analysis from Amulet IDE, Dr. Al Cooley's large NCDR evaluation, show that probably a 3 millimeter threshold still indicates a higher risk for stroke, and stopping anticoagulation could be a problem. Why does it happen? This is the problem of mismatching a device that wants to be round in an elliptical left atrial appendage that's mobile. And some factors we know increase the probability for leaks. Persistent AFib, dilated atria, big left atrial appendage, device placed too deep. And sometimes you go place the device, Watchman or Amulet, and it anchors. You can't quite tell underneath the surface. You're still attached to it with a metal cable that has some rigidity to it. Release the device, and the device retracts into the appendage a little bit and opens up a channel of flow over the face of the device. So some of these leaks are obvious when you implant them, and some of them show up later when the device settles and shifts and starts to heal.
What do you think is there a fundamental difference in the incidence of these leaks between a single closure mechanism device versus a dual chamber mechanism closure device?
Well, I mean, the best, I think, head-to-head comparison of those types is probably from the Amulet IDE, where we certainly saw an increased rate of peri-device leak with the Watchman 2.5 compared to Amulet. The concept there, really, the device is just more occlusive. It's more dense and more rapidly occludes the appendage with Amulet. The counterbalance to that a little bit was risk of the implant. But with Watchman, it's really a single piece of fabric covering the ostium. So sometimes you'll see leaks. It's actually just kind of flow through a fabric that's not totally endothelialized. And so depending on when you image, 45 days, 90 days, 6 months, you can see some of these leaks disappear. But the ones that run around the edge of the device and create, what I would dub a neo-appendage, this is like a term I've come up with. It's like a new appendage created by putting a device in the ostium, and then flow is established and creates a new cavity under the device. And depending on what type of device or what it looks like underneath, you could have variable degrees of thrombus and endothelialization under the device. So that probably factors in a little bit to the increased stroke risk after we've created a neo appendage. But generally, I think the dual seal mechanism seems to be probably tighter, more rapid occlusion with less leaks. And a lot of those leaks are also probably not relevant when it's just seepage of contrast through the disc on a CT scan, where if you're looking at it with CT versus TEE, you may see a leak on CT, but you wouldn't necessarily see any Doppler flow on TEE.
Well, there seems to be quite a bit of confusion about what a leak means when you use a TEE versus a CT scan. Right, so can you throw a little more light on how do you really define a leak for a single closure mechanism device versus a dual closure mechanism device on a TEE versus a CT scan?
Yeah, so I think when you see like visible separation of tissue between the device edge and the ostium on a 2D echo with TE, you'll generally see a space, and then you put the Doppler flow on, you should see a jet of contrast. If you see a cavity of black space underneath a single occlusive mechanism device, such as Watchman or Watchman Flex, there's got to be a leak somewhere, so you have to find it. Now, when you do CT scan, I've seen cases where it really looks like the device is perfectly positioned and there's really slow trickle of contrast into the appendage, and depending on who's reading the CT, they say there's a leak of contrast into the appendage, but there's not really a separate identifiable channel of flow around the device that you could address. So it's just, like maybe it's coming in from drainage of the veins on the outside of the appendage, or it's just seepage through an incompletely endothelialized fabric until it's totally occlusive. With Amulet, it's a little bit harder sometimes to see peri-device leak around the lobe on TEE. But you will see that more clearly with CT, so sometimes that can be helpful if you're thinking there might be a leak around the lobe. When we see a little flow around the disc on TEE with Amulet, I've seen a lot of those actually disappear by a year, and I think it's just as the device continues to settle and the disc sticks to the atrial wall, everything from underneath is sort of fibrosing up towards the disc surface. Those little leaks around the edges of the disc a lot of times disappear. But they're probably not relevant to go after, like they don't indicate necessarily that there's a neo appendage anymore, right? It's just creeping around the disc edge, and gradually that'll generally seal off over time.
I mean, being all things equal, we know human left atrial appendages are quite heterogeneous in their size and shape and things like that. How do you decide which device to use in which patient based on the anatomy?
It's a good question. Like generally, I think any device fills a windsock pretty well. Chicken wings, depending on how long the neck is, Amulet can be helpful there because it's a little bit more shallow implant. It can be placed tighter to the ostium. I think when they're really elliptical, it's another one where I might think the disc covering that entire surface is going to be of benefit no matter where you anchor the lobe. Whereas with a Watchman, if it's super elliptical, especially when people are tending to over-compress the devices now, you probably leave a gap around one corner of the device. So I think in that way,
you're really one of those well-established experts in the space in the country now. You've been part of several clinical trials involving left atrial appendage closure devices. So what's your personal recipe in mitigating, that means avoiding leaks and also fixing them if you need to? So walk me through how you plan the procedure, how you do the procedure, and when do you say, I really like this place, so I'm satisfied with the stability of the device or the location of the device and I'm going to deploy it or not?
There's a lot to unpack there. First, pre-op planning, CT angiography. If I can get it on most patients, I like to get that pre-procedure. There's been some evidence that will make it more likely that you're only going to pick one device size for the implant. Like you'll more accurately match the sizing if you have a pre-op CT. So I like that. That helps me a little bit on device selection as well. Intraprocedurally, it's really important to have good imaging. And real-time ultrasound imaging, if you have a good 3D TE, somebody else managing the probe, and they can show you the views you want, like that's ideal. That's probably the gold standard for imaging. Intracardiac echo is making some traction, and it definitely seems to facilitate quicker in-room and out-of-room on the whole, without a whole lot of difference in device position, leaks, and that type of thing. But really, you want to be diligent about the intraoperative imaging before release. Make sure that you're not too deep. And a lot of times, you kind of have a suspicion of that. If the distal part of the flex, say, is really tightly compressed, it's probably caught in a lobe, and you might anticipate that it's going to retract when you release it. To some degree, you can't entirely predict that, though. As opposed to like when we used to do Watchman 2.5, we'd have some predictable shift in the device when we released it, and you could almost count on that. We don't see that as much with flex, so you have to be more mindful. Distal anchoring could lead to a shift in the leak. With amulet, I really go for tight lobe. And I think if the lobe is anchored really well, the disc will follow it and seal the entire appendage. If you put the lobe in low compression, trying not to oversize it, I just feel like it might shift a little bit depending when you release the device, and that can affect the disc position. So I don't like to see the disc move much when I release it. The way to avoid that is to make sure you have a big enough lobe that's anchored tight, and then when you come off it, the disc is going to stay put. When they're a little bit smaller, they'll sometimes tend to tilt just a little bit, and that disc might pop down under the PV ridge, setting up a risk for DRT, or might top hat off the mitral valve annulus a little bit if it goes the other way. So I think that's how generally. And one way to anticipate that is doing an angiogram through the lobe before you deploy the disc. So I like to put the lobe out, looks tight on TE, contrast shot, make sure there's not anything you're really missing much with the lobe before you go and deploy the disc, because you can't see that afterwards. Once you put the disc out, you shoot contrast at it, you really don't typically see much contrast get past the lobe.
So oftentimes the popular practice with the Watchman Flex device is you try to oversize it significantly, looking for a 25 to 30% compression rates on this. Does the same principle apply to an amulet, and how can, say, a novice that has never done an amulet device, say, wants to start a program like that, what kind of compression should they shoot for? What kind of endpoint are they looking at to mitigate a PDL, at the same time really having a successful implant?
I mean, I think going to like Watchman degrees of 30% compression, that's way too much with amulet. But I also think like that they give you this range of sort of 3 to 6 millimeter oversizing for the device based on the landing zone measurement. I tend to go a little bit more like 4 to 9, like push it up just a little bit, because even when the lobe is tight, you don't want to leave a strawberry-shaped, like mangled lobe. But if it's a barrel and it's tightly squeezed, the anchors actually pull back just a little bit from the edges of the lobe, and so they may not be as much of a risk for pericarditis and perforation. So I think when you leave a big lobe, actually I'll take this, the bigger the lobe, the more compliant it is as well. So when you go up in sizes, I actually think you soften up the lobe a little bit. The smaller devices, the lobe is fairly rigid, and so like if it's not compressed much, but it's in the tissue, is actually, the anchors are sticking out pretty abruptly from the edge of the device. So a little more compression on the lobe actually may retract them a little bit, but you don't want to overdo it because you may lose anchoring.
Well, I mean, we know that over all these years we learned that smaller leaks are better. From that standpoint, our targets moved from 5 millimeters to 3 millimeters now, and some people are saying 3 millimeters is not good enough anymore. So in your personal opinion, what is the minimal acceptable leak that doesn't worry you, versus will there ever be a day in the evolution of this closure device field that we would get to a zero leak scenario?
Maybe on the zero leak, right? Depends. We got a lot of technology being developed. There's clinical trials on some newer devices that could help mitigate that. But I mean, really, when it's a dynamic elliptical object and you're putting a round device in it, getting to like 0.0 leaks is going to be tough. If it's a millimeter, I think you're probably fine, honestly. 2 to 3, I've seen those grow to 3 to 4 to 4 to 5 over a couple of years period of time, because I mean, AFib is a process, right? So the atrium continues to remodel and dilate. Patients' left atrial pressure may go up over time depending on their comorbidities, and it can expand the cracks around the edge of the device and make the leak larger. So it warrants further surveillance, but whether you need to go after every 2 millimeter leak or not, I think is still up for debate.
So one final question. How do you manage leaks between a single lobe device versus a dual lobe device? How do you really monitor them?
Yeah.
And what do you think is different about in terms of overall outcomes between these two scenarios?
Well, outcomes we know from amulet trial for sure that the patients with a 3 millimeter or greater leak tended towards more ischemic stroke and higher cardiovascular death rate at 3 years follow-up. We actually had a poster on that here at this HRS. So I think there's a real signal there that we can't ignore. Leaks around a Watchman generally, as I said, are like a cavity, a channel, something you can get into. And when you get into it, if you get deep in there and there's this big, like I call the neo appendage back there, I mean, really you either have to fill the entire cavity with coil, which I've seen some of the centers doing these and reporting, you know, an average of like 4 to 5 coils. I mean, I'm like 10 to 20 coils. It has to be totally packed. Because when you look on fluoroscopy after you put these coils out, it looks super dense, but there's still a ton of empty space. It's not really occluding. So you either have to fill the entire cavity with a coil or get another device like a plug, an ADO2, an AVP, something that you can squeeze into that channel to choke it off. Those work pretty well. I'm not really a huge fan of like the combo. I mean, I feel like pick one. Okay, like why you put a plug on top of coils, I'm not sure. But in general, I think you got to get rid of that if it's 3 millimeters or more, especially if the patient's had TIAs or strokes or recurrent events, right? Again, the smaller leaks, I mean, there's a lot of debate about using RF and other things, but I think most of these 1 to 2 millimeter leaks that we just observe, we don't necessarily do anything at this time.
Well, looks like the bottom line is appropriate procedural planning, sizing, based on anatomy, choosing the right device, and then being able to really deploy it properly with proper alignment seems to be the magical solution here.
Yep.
Thank you very much for talking to me today, and enjoy the rest of the Heart
Thank you,
Rhythm
DJ.
Society meeting.
Appreciate it. Thank you.
Thank you.